are the blood panels available today that can help a physician get a better indication as to what's happening in the blood and potentially which current prescription drug is available and is best for that patient?
So that is exactly what we are working on in my lab. So as I said, I'm at Mass General. I have an NIH-funded lab that looks at clotting. What we have used is there's a test out there called thromboelastography, or TEG, T-E-G, okay? Thromboelastography is a fancy way of saying I can take a blood sample from you, I can put it on a little credit card type thing and stick it in a machine, hit a button, and it gives me a chart that tells me exactly how thick and thin your blood is and what aspects of the clotting, what part of that pancake is being affected. Now,
Wow.
the thing about it is, so what if I can tell you that? Let's say I can take your blood today and I can say, yeah, Kim, you know what? Your platelets are doing this and your blood clotting is doing that. A doctor would be like, that's great. What do I do with this? Do I give her Eliquis? Do I give her? Somebody has to also discover, well, what is the magic number at which your body will not clot, but also not bleed? Because I don't want to overshoot, give you too much, and now you're having a brain bleed either. So what we did for the first 5 years in my lab is we found that number. We took blood from a bunch of patients, 100-something patients, and we actually analyzed it on the TEG machine. Of that 100-something patients, there was a particular proportion of them that did clot. And we looked at their TEG numbers and found that the TEG numbers, 1 month before they clotted, can predict that they were going to clot. And then we identified at what level of platelet function they actually clotted. That's a mouthful to say that I can now take your blood, see where you are specifically, and then treat you accordingly to make sure that you don't clot and you don't bleed. And we've implemented that now already at Mass General in a study.
You have a lot of research that you're doing that could help. And I would imagine it would be hematology that you would go to, to have these additional blood tests performed.
Actually,
It wouldn't be
no. The beauty
really.
of this is you can do it anywhere. That's the thing. What I wanted to
Oh,
do
wow.
is I didn't want a situation. So when I started, this problem is a major problem. 1 in 5 people, 1 in 5 who get a procedure will be back within 6 months for a repeat procedure. That the number is 20%. So 20% of people who get intervened upon will be intervened upon because they either clot off or they get tightening of their stent or whatever we did to them to open up their blood vessel. Mm-hmm. And obviously that means that they're taking blood thinners that are not working for them. So they're taking all the bleeding risk and yet get these unfortunate situations. And what I didn't want is, we've been studying this problem for years and years and years and have not really come up with a solution. And the way that I look at it is, think, for all of you that are diabetics out there, think about how you manage your diabetes. What do? In the morning, you take a finger stick, right? Or you have the thing on your arm that checks your blood and it gives you a number, right? And it says, hey, if this number is greater than 120 or less than 80, your blood sugar is out of whack. I don't care why it's out of whack. I don't care that it's because you just ate a whole box of Dunkin' Donuts or it's because you forgot to take your insulin last night. Whatever the reason is, this is your number right now, and this is the treatment. I wanted to do the same thing for blood thinner. I don't care if you have a genetic problem, if you didn't take your meds, if you're a 5-pack-a-day smoker, if you're black, if you're white, if you're a woman, if you're a man. All I want to know is, what's your blood doing right now? Because this is the treatment. That's what I was trying to create. And so what I did is, this test, this thromboelastography, already exists. It's been around since 1948. But we've been using it for bleeding, not for clotting. So what happened in the Iraq and Afghanistan war is our soldiers were stepping on basically landmines. They were blowing their legs up and they were bleeding torrentially. And our trauma surgeons were doing this TEG and ROTEM, that's basically the same thing, and checking their blood and saying, okay, you know what? This soldier needs platelets. This soldier needs red blood. This soldier needs this soldier needs, to make them clot. So they were checking their bleeding, not their clotting, because the soldier was bleeding to death. And then they were giving them the appropriate components to get them to stop bleeding. My idea was, why can't we do the same thing just in the opposite direction? Look at the components of blood and get them to stop clotting. So I started using TEG, and there's special cartridges, and they're not expensive. Because they've been around for so long. The only thing is that this company, so Hemanetics is the name of the company that makes this test. Again, it's been they've been using it for bleeding because that's kind of what the market has described. But basically, what this test does is it checks your blood and tells you at that moment what you're doing. But somebody else had to discover then, okay, what do we do with that information? So first, I in my lab figured out that I can do TEG on patients with PAD and identify over the course of 6 months, I took their blood at multiple times, what their coagulation profile was, what their clotting profile was over 6 months. Then the patients that clotted off, I looked to see, hey, did this TEG blood thing predict who would clot? And it does. And then I figured out what was the number at which they were clotting. So basically what I'm saying is, somebody figured out for blood glucose, the magic number is about 100. 100 is normal. So I did published a paper, and my team, of course, that identified that if your platelets are kind of dysfunctional at 30%, so 30% inhibition, that's when you don't clot and you don't bleed. And again, this is just the first iteration of it. It's going to take time to really hone down, but that's a good number to start with. So then what we did, and this is where we are today, is we said, all right, let's test this right away. We take permission from our patients at Mass General who get PAD interventions, and we ask them if they are okay being a part of an algorithm. So what's my algorithm? What I do is a patient comes in, I do a procedure on them, and I start them on what is essentially the standard of care, aspirin and Plavix, those two drugs. Start them on that. And then in 7 days, and why 7 days? Because the life cycle of a platelet is 7 days. In 7 days, I check their tag again. And if they haven't hit 30%, it means the drugs are not working for them. So then what do? I send them for Plavix resistance testing, because remember I told you 1 in 4 people is completely resistant. And I replace their Plavix with a drug called ticagrelor or Berlinta, which a lot of your patients may be on. Why? Because Berlinta and ticagrelor, which are the same drug, are in the same drug class as Plavix. They're just a stronger drug and less people are resistant. And then I check the blood again in 7 days. And if they've hit 30%, they're treated. So, and if they don't, we manipulate, we do. And over time, if they overshoot, they go too high, we bring them down again with other medications. So it's sort of a, I'm testing you, I'm treating you. I'm testing you, I'm treating you. In kind of checking your blood glucose, giving you the insulin. Not just one size fits all, right? And what we've discovered is our historical rate of clotting within 6 months was about 20% at our institution. By implementing this algorithm, it has dropped the clotting percent to 3%. So
you're kidding.
Significant drop. Now, again, it's not perfect. We're absolutely in research testing. You cannot go out today to your doctor and say, I want a TEG test, because it doesn't exist for you currently, because it's not the standard of care, because we're testing this. But if you are at Mass General, you will have the opportunity to enroll in the study. But we're not doing anything special with the blood thinners. That's the key. We're not inventing something new. We're just checking your blood and making sure that the blood thinners you're getting are actually working. And if they're not, trying to tease out what other blood thinners we can use. So we're taking all the tools that already exist in the world and just using them what I consider more intelligently.
I mean, what you're saying is logical. I mean, it really makes sense. So I'm sure that you've talked at different physician conferences and with different peer groups about what you're doing. What resistance have you faced in support for this particular research and implementation?
No resistance. People are
None.
thrilled and excited about this concept. I have a couple of grants that are under review with the NIH, the National Institute of Health. The biggest thing in medicine, I'll tell you this, okay? So I work at Mass General, as I said. Mass General is special because it's the place, many inventions have come out of there, but one of the inventions that have come out of there was the discovery of anesthesia. And there are articles that were published back in 1846 when anesthesia came out, where very powerful surgeons were saying, anesthesia, this is humbug, this is ridiculous. Patients need pain for surgery. My point is, anytime anything new happens that challenges what the status quo is, there's a lot of people that have been living in the status quo for a long time that have difficulty accepting something new and novel. So the point I'm making is it's going to take some time for people to come around, but face-to-face, people who do PAD are very excited about this and ready to accept it. We just need more research in this before we go out there and change what we've been doing for the last 50 years.
And I think that that's what doctors that I've talked to have actually brought to my attention when I've shared that one study, the publication that you came out with that talked about your initial stages of this research. And they said, well, nothing to pay attention to yet. And I said, actually, it is something to pay attention to. I mean, yes, more needs to be done. But as a doctor, I would imagine you would look at that study and it would make you think twice and go, oh, wait a minute. Maybe every single time I do prescribe these, I do need to keep a better watch on these patients. And if a patient does come back in 6 months for another procedure, maybe I do need to take a second look at what blood thinners they're on. And for example, if they are on Plavix, maybe do the resistance test at that point versus doing 6 or 7 more procedures over 2 years, right? And get that revolving door of procedures continuing without stopping it and saying, wait a minute, can we make any other changes?
So what we need is more focused research. I encourage you to look at the stuff that we're doing, and I would love to share it with you more. And hopefully we have something published within the year, which is the pilot study, which I described to you about the discrepancy and the decrease in clotting if you do something targeted.
I can, listening to the last hour, I can see and I can feel it here in Texas, your excitement about what you see the future and how do you see this innovation affecting saving lives and limbs in the future and changing the course of how PAD affects people and how it affects amputations and that process? It's listening to you was like, oh wow, oh wow, oh wow.
Thank you.
You know, it's like so, and you can see that. I think we can see that excitement in like what Tim's saying, in how you're doing and are going to make a change in this research and how it affects
Oh,
PAD.
I sure hope so. Thank you, sir. No, that's the thing. You know, I would never, if somebody told me, listen, you have cancer and I'm going to give you this medication. Okay. I'm going to give you this chemo. And just so you know, 1 in 5 people who gets this chemo die. I would be like, what? What are you? I'm not taking this drug. 1 in 5 people it doesn't work for. You don't have a better way of doing this. This is terrible. It's 2024. But that's what we do with blood thinners. 1 in 5 people. So think of the millions and millions of people that have PAD, right? Every day going and getting these procedures. 1 in 5 of them, it doesn't work. Imagine if, and 1 in 4 of them, they're totally resistant to the medication. And you know that 1 in 4 people are resistant, but you give it anyway. Like what? So that, and then, so let's say you get the same blood thinners as, Nancy gets, let's say, okay? And for whatever reason, you come back in, a month and your leg is clotted off. And the doctor is like, oh, did you smoke a cigarette? You said, well, I had 1 cigarette 2 weeks ago. And they're like, yep, it's your fault. You did that. That's why this happened. But actually what probably happened is the 2 medications that they gave you, one of them totally doesn't work. So Nancy got treated, but you didn't get treated. And so my whole thing is like, I'm coming in at 2 o'clock in the morning to do a 6-hour bypass on somebody. And then they walk out the door and they come right back in next week with their leg clotted off, and I'm chopping it off and dealing with the family. And like a year after I've cut off their leg, they're dead. All because I just didn't give them the right blood thinner. I can't live with that. So my whole research is about, you know what? I'm going to change that number to 1 in 50 people come back in 6 months, not 1 in 5. Because with the raw number of people with PAD, which by the way, I mean, we know PAD kills more people than the 3 top cancers combined. And the reason people die of PAD is because they end up dying of a stroke or they end up dying of a heart attack because they have this disease across their entire body. Well, guess what? These blood thinners I'm talking about, they work on those 2 things too. So what you're doing is you're treating people with the wrong thing and patting yourself on the back. And that paradigm shift needs to change. It may not happen in my lifetime, may not happen in the next, but the start of, the beginning of any innovation is not accepting the status quo. Like right, I just saw today, I was showing my kid, because my kids were like freaking out. They know I'm a softie. So they're like after me to give them candy. And I finally was like, you know what? You're all going to get diabetes. 1 is 4 and 1 is 7. And I'm like, and they're like, what's diabetes? So we watched these YouTube videos about diabetes, and now they're like terrified. But anyway, the point is we looked at Banting and Best were the guys in Toronto that identified insulin. They figured it out. And you should see the story of how they figured it out and the fighting that happened and how many people tried to block them. But they they couldn't tolerate that all these children were dying on the ward in Toronto. They were slipping into comas with diabetes and dying. And the surgeon, the guy Banting was a surgeon, and everyone thought he was sort of an idiot because he was a surgeon and he didn't really have a deep understanding, sort of like me. Like a lot of times people are like, well, you don't know anything about hematology. You're a surgeon. I know enough to know it's not working, bro. So, that's enough. That's all I need to know. Whatever you're doing, all your talking and all your papers are not working. So that's the same thing. Banting was a surgeon, and he went to an endocrinologist and a couple other people, and together they figured this out. But it took years of pain and a lot of naysayers. And you just have to keep trudging through that. And that's like the most difficult part, because people accuse you of all kinds of things. Like, well, you're going to hurt patients if you take away one med and give another, or like, and you have to kind of just say, no, I know I'm doing the right thing. And someday, you'll be coming to my talks and saying, oh, I always believed in this.
And that's interesting, because Kim can remind us. We had a doctor on one time who said he learned a procedure, or they learned how to do a procedure in his mom's kitchen. And it's like, it started from there, and it sounds like what you're trying to accomplish now for us.
Yes. And I'll do it. Don't worry. I'm sick of cutting off. I distinctly remember I had this patient when I first started, her leg gets chopped off slowly, and it's like bit by bit. They took her toes, and they took her foot, then they took her leg, then they took her other leg. And then, and I'm like just trying to she had multiple children. She was only in her 60s. And then one day I just get a call. She stroked out and died. And like, maybe she was on the wrong, well, she probably was on the wrong meds. And she had diabetes, but she wasn't a smoker. And like, but people just sort of were like, this is the way it is. Well, nope.
It's not acceptable.
Yeah.
I do want to clarify one thing, that so many of these patients, when they go back and they have the revolving door of treatment, the doctors are telling them they just have a very young healing and overactive healing response. And I'm not sure if they're using IVUS, the intravascular ultrasound, when they go back in, they might have a better idea on the morphology of the plaque, maybe. But how do you know if it's the scar tissue, the healing response, or is the issue with the platelets and the clotting also a healing response?
Oh,
how do you know which one?
It's both. It's absolutely both. So it's well known that, like, the issue with the platelets and the clotting and stuff. So a lot of the stuff that's out there for long-term patency focuses on basically things shutting down after 6 months. So everyone's focused on that because that's when the scar starts to form. People have sort of neglected the patients that have drama in the first 6 months. And that is usually because the blood thinners are not working. And people didn't know what to do with it, so they just ignored them. But usually, the thing about this is that it's a combination of all kinds of things. Like, let's say someone put a stent in you, but they undersized the stent. Like they should have put in a 7 millimeter, but they put in a 6 millimeter. It's well established that the undersizing of the stent causes quicker tightening of a stent. But, nobody has ever done, we're really, like I said, we're really like standing on a beach digging at the sandbox because we don't know how all these different variables come together. In the cancer world, in 1970 something, Nixon was the guy who figured out that we need to invest in this. So many people are dying of cancer. So many Americans are dying of cancer. We need to, put money into this. And so Nixon gave a ton of money to the government and the NIH and said, go and give it to researchers and get me a cure for cancer. I don't want to hear anything else. Just get me a cure for this. And they invested in it. And that's why today we have such advances in genetics, in the type of cancer treatments. Even Biden has called it the moonshot project. Again, moonshot, there's such a focus on it. But P.A.D. that kills and hurts more people, people don't even know what it is, let alone like what to do about it. So we have a lot of work to do. And I think it starts with public awareness, like what we're doing right now. And that will put public pressure on the government to say, I need you guys to invest in this so that 50 years from now, when we have an avalanche of diabetics, which we're going to in 2045, we're ready for that.
Yep. Thank you so much, Dr. Anita Dua. You can follow padstories.com, and we'll be publishing any new research from Dr. Dua as soon as it comes out. Have a great weekend, everyone.